Welcome to the Open Voice Network and the Future of Voice podcast, where we explore the today and tomorrow of conversational artificial intelligence. I'm John Stein, Executive Director of the Open Voice Network, your host for today's talk on the new conversational AI, the world of language models and generative AI, and the world of healthcare. And with me, two wonderful experts and leaders in healthcare and AI, Dr. David Metcalf, Director of the Mixed Emerging Technology Integration Lab, METIL, at the University of Central Florida Institute for Simulation and Training, and Dr. Dexter Hadley, founding Chief of Artificial Intelligence at the University of Central Florida College of Medicine. Gentlemen, thanks for joining us. Delighted to have you on the show. Many of us are generally familiar with the technology of generative AI and large language models, ChatGPT, etc. And millions have engaged with one or more of these systems, which means we have mostly all moved on from the questions of what is it to the questions of how we'll use it and the implications therein. David, let's start with you. You're a recognized leader in the application and use of advanced technologies. This is a remarkable tool for accessing and generating knowledge. Paint for us, if you will, this broad picture of the greatest opportunities for conversational AI in healthcare and maybe touch on the greatest potential risks, please.
Certainly. It's great to be here with you. And we had a lively conversation at HIMSS on this topic at the co-hosted event that we had there too with the AI and Machine Learning Forum. And many use cases came out of that too, as well as many concerns. Some of the top ones that we've been discussing at the Open Voice Network and looking at some of the direction that we're taking is really this concept of mass personalization. How could we leverage AI for precision medicine that's understandable by the patient, that is easier to provide information for the provider networks and the doctors and nurses? How can we figure out the best way to use this technology for either the triple aim or the quadruple aim? How can we have better care that's faster, that's less expensive, and the fourth aim that doesn't burn out our healthcare providers? I think there's great promise in AI and the voice interface supporting it for making things explainable, making things easy to access than ever before. And that's been a really exciting to see and eye-opening for how that could happen. There's also great potential for AI to come up with new treatments, new cures, of course, in conjunction with world-leading experts in this and an appropriate testing system and standards. Those are some of the things that were discussed in great detail. There was also a number of concerns over privacy and over data sovereignty and over the whole idea of how much do we want this AI technology to know about us to produce that precision medicine and those personalizations for our care versus when does it become too invasive and how is it going to be used and by whom? Those are all things that were addressed in great detail. There's no answers just yet, but it's been nice to see your organization, John, go through the process of announcing and having a big splash for Trustmark and what that can bring to the table for us too, in terms of taking one more technology that I really like too, blockchain technology or other ways of verifying identity, verifying the veracity of a record, and being able to apply that for what we hope will be an equitable way of providing healthcare for all and providing a means by which people can have some control of that information and decide how it can be used and who it can be used by. I think that that's something that is one of the risk points that's still in works. Appreciate all of the efforts of the organization. And the other poignant quote, probably the quote of the day from those sessions was, AI is not going to replace your doctor. However, doctors who use AI may replace your doctor or doctors who don't. So those are some of the things that I thought were kind of telling in terms of those use cases. I know there's a little bit longer answer, but there's a
No,
lot to
David.
unpack there.
No, David, thank you. And you brought up critical issues, privacy, data security, control over your data. These are broadly issues of trust. And Dexter, let's turn to you. Unpack for us this, even more so, the concept of trust in healthcare. From a patient's perspective, a provider's perspective, what does it mean as a clinician, as an educator? Talk us through that, the risks, the harms. Give us that background.
Yeah, thanks. Thank you, David, and thanks, John, for asking that question. I think trust is critical to patients, providers, and sort of the system to provide quality healthcare. I think healthcare is a really interesting field because we've had laws in place sort of before maybe any other field for HIPAA and then the Electronic High Tech Act and certain laws in place that protect privacy. HIPAA, the P in HIPAA is for portability. HIPAA is meant to share for patients to securely and trustworthily, share information with scientists and providers to improve outcomes. Yet you find in American healthcare in particular, there is disparities of trust, let's say, among the patient population. I studied, I have a PhD in genomics and computational biology. We founded new drugs through, this idea of precision medicine that David talked about. When you study autism in a top children's hospital in like the Children's Hospital of Philadelphia, and you study 30,000 kids with and without autism and ADHD, about 99% of those kids are from a European-derived sort of ancestry. And when you have, no evidence, there's no precision outside of that European-derived, so for whatever reason, there's very little trust in the patient population itself. In a place like Philadelphia, which is extremely diverse, and autism is across the board. So there's no evidence for most of the population. And that scales to all diseases. And this is just precision medicine. We haven't even gotten to AI. So this issue of trust is critical, I think, in finding the evidence, right? So we're in the age, I work in medical school, I teach the future doctors of America, evidence-based medicine. We've been doing it for 20 years. And I think the evidence now is in the data. And the data suggests that we have a long way to go before anybody's going to trust the system. I mean, the data suggests we're on the verge of another pandemic of bias in said data, and we can talk about what that means. So when I hear precision medicine, I say, great, that works fantastically precise in breast cancer, for instance, in a certain population. And it works exactly the opposite way in a different population. But just honestly wasn't tested. Clinical trials demonstrate this bias very, very clearly. And I really see initiatives like the Trustmark initiative, some of these transparent initiatives, and blockchain, and sort of some of these technologies that bring a level of governance, a level of accountability, a level of community. Blockchain is engineering of trust, so to speak, in communities. I see that as a way to draw out transparently what is wrong with the system today. There's a huge level of bias that Dr. Metcalf and I have talked about and actually wrote about. So I think it's critical if we expect precision medicine to be accurate for most people, which is not today. There's just no evidence that it works for most people. If there's evidence, it works very well, in a certain population, but across the board, we need to generate much more data in a trustworthy environment where the data is accountable, so that we can have improved outcomes across the board.
Improving outcomes across the board, a greater level of trust, and bringing precision medicine up to that necessary level of trust. If I'm hearing you correctly, Dexter.
Put it this way, in 2013, I believe, which was maybe 10 years ago, 96% of sequence studied, period, was European derived. It's genetics. We know where it came from. And Carlos Bustamante out of Stanford published that. I think the number is like 85 or 80% today, which definitely is not across the board, right? And that's before we even got to the AI. So I think it's critical that we address this issue head on, to improve sort of the yield and the potential for AI to equal, to bring gains across the board. I think across the board is appropriate.
David, in your work, what Dexter identified a critical issue here, and what do you see as some of the either the tools or the processes that clinicians, researchers, and the like can be taking, put in place, apply to the situation that Dexter just spoke of?
Yeah, so there's a number of things that Dexter said that tie to certain technologies. A few that we should look at are natural language processing, of course, and generative AI and blockchain, kind of the trifecta of those. And some of this comes down to cybersecurity and privacy, and some of it comes down to access. So I think that natural language processing, especially across multiple languages, multiple dialects, can be quite helpful. Things like near instant translation for people could be very useful. And the idea that you, just like you have a fingerprint, you have a voice print, and that could be part of a multi-factor authentication that you would use to ensure greater privacy and protection without adding to the cost of that. If you have artificial intelligence in the mix too of some sort, you might have higher context where there's maybe not a full understanding of the meaning, but the way the words come together through natural language processing, when AI filters it, it might understand the context of something that sounds very similar. The example I've used for years is hypodermic and hypodermic. If you get that wrong, there could be great consequences, but the opposites. Those are some of the things that we have great concern over. So that's something that I want to make sure that we think about and that we look at, thoughtfully in this process. Having those other factors for authentication, like blockchain, to make sure that you understand the rights that someone has with your data and that you have with your own data, and tying that into this easier interface could be quite compelling and help with establishing and maintaining the patient's trust, hopefully the clinician's trust too, in this technology. Think about some of these technologies, if they had context awareness, how it might be able to automate some of the notes, and then of course have the doctor go back and do a review pass. But we see the amount of time that doctors are spending with their electronic health record systems versus the time of hands-on care with the patient. If we could change that ratio for the better to the patient, I think that would have certainly potential for clinical outcomes, but also quality of life for the healthcare providers, doctors in particular, and nurses. But those are some things that hold out great promise if we can get this right. And I think that that's why it's worth pursuing.
Yeah, if we can get it right. But David, you just mentioned, and Dexter, turning it back to you, David mentioned, just the use of NLP, NLU to, if you will, expand the reach to include more than, say, Europeans within this, to include more the use of conversational AI to perhaps create greater efficiencies, spending more time with the patient, less on electronic health records, any number of things that would be values and benefits here. You're the chief of artificial intelligence at the UCF College of Medicine. What are you teaching? What's most important for the students to hear from you in terms of where this is going, what the future is, dealing with the issues of trust, dealing with their futures as future clinicians and providers?
Yeah, I think it's it's quite striking what is happening, right? So you have, let's take ChatGPT, but the large language models, if you like, because there's a bunch of them, that can pass USMLE, which is the medical licensure exam for physicians. That's an interesting fact. And it has turned medical education on its head, in a sense. How do we, so inevitably, we all know ChatGPT is the most viral app ever. There's no industry that's going to be immune from this, including medicine. And I can argue, there are huge consequences to getting it wrong in medicine on patients. There's very little consequences to getting it wrong in medical education on students. So I can argue you're going to see a lot of innovation in medical education, teaching students to leverage. So you ask, what am I teaching them? I'm trying to build this idea that, well, clearly students can learn how to pass USMLE at least as well as ChatGPT in the future. At least if we can just engineer some question answering, and so can law students, and so can every other student. I think a lawyer just got in trouble for citing ChatGPT's hallucinations, if I'm not mistaken.
Yes.
Yeah, I read that somewhere. So the same risks exist in medicine. I think any engineering group can tell you these models only work on context, they don't have entity recognition. I think these problems can be solved. And to my initial point, where 90% of clinical trials are biased toward whomever. Imagine if you had a natural language interface to clinicaltrials.gov, which already is open. You have HIPAA, you have, I kind of see blockchain as the renaissance of HIPAA, because HIPAA really is meant to de-identify you beyond re-identification for privacy reasons. I think blockchain allows the re-identification, which is now interactive and can build trustworthy communities if we at least teach kids, if we at least teach the future doctors of America how this could work, right? So, I think it's a fact that patient outcomes are better if your doctor looks like you and comes from the same culture, and you can understand that for sure in mental disease and psychology and psychiatry and this type of thing. I mean, it just makes sense. But even in diabetes and childbirth and cancer, that also holds true. Now that's a problem when only 2 or 3 individuals in my class of 100 and whatever are of minority descent, right? So I think training less biased, building interactive natural language interfaces that regular people can speak to. So, I work in the VA. The VA is the largest electronic health record probably in the world and the longest running. It's dirty, but ton of less biased data is found in the VA. Imagine if we can ask the VA system, hey, VA, I'm a patient. You know my background. Tell me what happened to patients like me, right? Just imagine if a patient could just ask that and be empowered to ask that in a trustworthy, transparent, clinical way. I think that's possible today with completely automated responses, and that anybody would use that service if you had cancer, right? And you can honestly have a response. Well, we don't know what's going to happen to you. That might be the response, but at least you would, at least we would get to a point where you might know. In Florida, the law regulates what we can and cannot say. Okay, let the blockchain say it, then I don't have to say it or lose my job, right? So I think there are a lot of ways to look at this to sort of make this benefit patients and engineer it to benefit patients and sort of leverage what we know is broken. And it's not the technology that's broken. Other things in medicine are broken, but I think this can draw out and correct. If initiatives like TrustSmart get extended into clinical trials, I think we have a win-win-win for everybody.
Final question for both of you, and 30-second answer, but you're going to both be speaking at FIME, an audience of practitioners, clinicians, consultants, interested parties. David, first with you, what's a takeaway that you'd want them to be thinking about? One thing from this conversation, you'd say, take this away, act upon it, do something with it. What might that be?
From today's conversation or from those that
Either one. Either
yeah.
one.
So the workshop is going to be just that. We're going to have some thought leaders, some panel session, and some actual hands-on where you get to experience some of this technology too. And I think that that's what I would encourage all of you to do, whether you come to the session or just from today, is to experience what this technology is and isn't for yourself. See where it's going to, and think and be thoughtful about where it's going to have a positive influence on the productivity, the health outcomes, the privacy that you hope to have for whoever you serve. And then also be thoughtful about those things that could be risks in your organization or for you personally. That's probably my best advice to you too. And certainly listen to us and see what our experience has been. But until you try these for yourself and experience how they're going to be useful to you, it won't truly be a personalized experience for your healthcare and your organization.
Dexter? You're on mute.
Definitely looking forward to the workshop with David, and I think this is the most viral app ever. It will, and it has surpassed Google search, at least for me. I'm going to Puerto Rico for 5 days with the baby, and I asked ChatGPT to plan out an itinerary. Incredible. I think that is coming in medicine, inevitably, one way or the other. And I think we want to welcome that in with open arms, sort of. And I would like people to leave at least our session excited about what that might mean for patients, for providers, for insurers, for payers, for everybody in the ecosystem, entrepreneurs, and clinicians, I guess, from my perspective, and educators, I guess, from my perspective. So we have some very interesting things planned, and I just look forward to sharing this excitement with others.
David, Dexter, thanks for your time. This has been the Future of Voice podcast from the Open Voice Network.